Hello students, welcome back to Easy Nurse, where nursing education made easy. So again we are Easy Nurse here for guide you. So for your upcoming exam. So in this session we are going to deal with the maternal nursing. Okay. So maternal nursing is nothing but like the nursing profession or the nursing field or the specialty of our nursing profession, which is mainly related with the maternity as well as the child health. Means mother and child health, how to get a pregnancy, then after getting the pregnancy what to be done and what are the things we have to follow during the pregnancy journey. So and after the pregnancy also, like how to delivering methods, everything is related with the maternal nursing, right? So let's start about today's session. So in this session I give you a one question paper. Okay, so like based on the important questions I prepared one question paper that I giving you, and based on that I am discussing the answer also, and along with I'll give you some more important questions for your upcoming exam. So let's start about today's session. So first see the question paper. So in the long essay I put outline the applications of maternal role attainment theory in an appropriate clinical settings. So this is the most important questions for the exam, that is the maternal role attainment theory in your in the applications of clinical settings. Next is write a note on the oxytocin. Second, enumerate the theories which is applied in the midwifery practices. So these are the three questions I have put, but mainly you have to write only the two questions. Okay, so totally 75 marks. So here this is the 10 marks for each. So 2 into 10 is equal to 20 marks you have to write in the long essay. Now come to the short essay. So short essay, total 7 questions should be there. Okay, so each question carries the 5 marks. So 5 into 7 is equal to 35. So you have to give the answer on the 35 marks for the short essay. Okay, so see the questions. First, explain the anesthesia and analgesia in obstetrics. So that is also one of the most important questions for the viva as well as for the theory and for the practical. Next, explain in detail about the adoption procedure in India. Next, explain in detail about the independent nurse midwifery practitioner. Next, describe the management information and evaluation system, or MIES, for the which is related with the maternal nursing. Next, describe the various biochemical and biophysical tests for assessment of fetal well-being. Next, explain the general physiological and puerperal changes during the postnatal period. And last is write a brief note on the organization of NICU. So all the questions are very much important for the exam. So please follow these questions and read the answers. Okay, now come to the short answer. So in the short answer you will get the 10 questions. So each questions varies the 2 marks. So 2 into 10 is equal to 20 marks. Okay, so see the questions: menopause, induction of labor, ectopic pregnancy, infertility, hyperemesis gravidarum, fertility window, lie and presentations of fetus, list the immediate care of the newborn baby, low birth weight baby, and list out the obstetric emergencies. Okay, so these all are the important questions for the short answer, but in between I just point out some questions which you have to read for the 10 marks also. Okay, first is the infertility. Next is ectopic pregnancy, induction of labor, hyperemesis gravidarum, and low birth weight baby, and as well as obstetrical emergency and immediate care of the newborn. So these all are the questions you have to write for the you have to read for the 10 marks as well as the 5 marks also. Okay, so don't depend on this like only it will come on the 2 marks. No, it is important for the 2 marks, but as well is it also most important for the 10 marks plus 5 marks. Okay, so last now focus on the questions and let's discuss the answer one by one. Okay, so first come to the long essay. So first question, outline the applications of maternal role attainment theory in an appropriate clinical settings. Okay, so first we have to know who introduced this theory and how it's related with the maternal nursing. So see, Ramona T. Mercer's maternal role attainment theory, which was introduced in the year of 1981, explains how the woman is become a mother and they're developing her maternal identity through their interaction as well as the adaptation procedure over time. So that is the maternal that is the attainment theory. So in the 2004 Mercer revised this theory and then it's renamed as a becoming a mother theory. Okay, sometimes in questions or in the exam they will ask you what write it about the becoming a mother theory. So that is also goes to the maternal role attainment theory, which was first introduced in the year of 1981 by the Ramona T. Mercer's maternal role attainment theory. Okay, and after that she revised on the 2004, and it's given by renaming is a becoming a mother. Now come to the concept. So what do you mean by the maternal role attainment? First is phases. There are several phases are there. First is anticipatory phase. So in this pregnancy journey, what is happening? They are learning the expectations and then preparing for the maternal role. Means mentally the mother is preparing herself for to maintaining the maternal role. Next is the formal stage. So from birth to about 6 weeks means puerperium period. So at that time the mother they starts performing the role according to others' expectation, because some grandparents are there, they are suggesting the new mother to do like that for the baby, for to do this for like this for the baby, right? So that is the formal stage. Means the mother they are taking the time for understanding what to do, when to do, and why to do. Okay, now come to the next, that is informal stage. So informal stage is nothing but like 4 to 6 months of the postpartum period. Means after the puerperium period the mother started to learning herself like how to develop their child. So that is the 3 phases: anticipatory, formal, and then informal. Now come to the next, that is personal stage. So it is a sense of harmony, confidence, as well as comfort in the maternal role. Now come to the next, that is influencing factors. What are the factors is influence the mother to maintain this role? First is age parity, socio-economic status. Next is a support system like partner, family, healthcare team. Next is the infant characteristics, as example temper tantrum, then health status, maternal self-esteem, and then mental health. Next is the cultural and environmental influences. Now come to the application in the clinical settings. What is this? First is antenatal or the prenatal care. So in this, what is the main clinical application? First is assessment. So as a nurse we have to assess the maternal expectations, emotional readiness, as well as the knowledge about the maternity role and how to take the motherhood. Okay, next is the education. So in this antenatal period, as a nurse we have to educate the mother about the fetal development, body changes, nutrition, birth preference. And now come to the counseling. So in this antenatal period we have to counsel about the fears by body image concerns and then role transitionary model. Okay, so these all are about the applications in a antenatal period. This is also one of the most important thing. Now come to the next, that is the example. So a nurse can facilitate the prenatal classes which help expectant mother explore their feelings about the motherhood, share experience, and build the confidence. Now come to the intrapartum period during the labor or delivery. So what to have to do as a empowerment. So we have to allow the mothers for take the choices like birthing options. Sometimes the mother they fear about the normal vaginal delivery, so they have right to choose for the LACS also. Okay, same like that. And now next is the pain relief method like intox masks as well as pain like sedatives, etc. Now come to the emotional support. So as a nurse we have to offer the reassurance and we have to try to reduce the anxiety level for the mother during the labor time. Next is the family inclusion. So in this we have to encourage the partner presence for enhancing the bonding as well as the supporting to his wife. Now come to the example. So a nurse midwifery allows the mother to participate actively in the decision making, which is reinforcing her sense of competence and then control, key components of MRA. Now come to the next, that is postpartum care. So in the postpartum care, in the sense like after the delivery period. Okay, so what should be done? First is observation. So we have to assess the maternal as well as the fetal well-being, bonding, and maternal self-confidence. Next is the guidance. So in that moment we have to guide the mother properly by providing the instruction on breastfeeding, newborn care, as well as recognizing the infant cues. Now come to the screening. So in this we have to identify postpartum depression and anxiety early and provide the appropriate referrals. So what are the example? A nurse, they observe how a mother interact with her newborn and provide the feedback like you are responding perfectly to your baby's hunger cues, you are learning to understand each other. So the boost maternal confidence. So if you provide this kind of phrase to the mother at the postpartum period, so what will happen? It will help the mother to boost their confidence about taking care of the baby. Now come to the neonatal intensive intensive care unit or the NICU. So what are the clinical application? First is facilitate bonding. So we have to encourage the mother for providing the KMC or kangaroo mother care, which is in NICU settings. Next is the involvement. So we have to involve the mother infant care routine as much as possible, and also education, like we have to teach about the infant's condition and then care needs as well as treatment procedures. So now come to the example. So a NICU nurse, they helps the mother gently touch and talk to the preterm baby, explaining that her voice and touch are vital for the infant's development and for strengthening the mother to infant bonding. Now come to the next, that is community and home visit. So what is the main objective? We have to continue the support for maternal role attainment after discharge also. So how should be the clinical application? Like follow-up assessment. So we have to monitor the maternal adaptation level, then emotional level, well-being level, as well as the infant growth and developmental stage. Now come to the parenting support. So in this we have to provide the education on developmental milestone, nutrition, and then safety for the baby. Next is the peer support. So we have to encourage the participation in mother support groups or the community programs. Now come to the empowerment. So we have to enforce the maternal competence and then independence in decision making process. So see the example, a community health nurse visits a new mother at home, observe the interactions and provides the reassurance that caregiving behavior is effective and appropriate. Now come to the nursing implications. So in this holistic approach, we have to address physical, emotional, social, as well as the cultural needs of the mothers. Next is the individualized care. So we have to recognize that each mother, they progresses through the stages of differently. Next is family-centered care. So we have to engage the family members as part of the maternal support system. Next is the early identification. So we have to detect the barriers to maternal role attainment. Example, lack of support, depression, poor infant health, etc. Next is the outcome evaluation. So we have to assess the maternal confidence, bonding the quality, and then adaptation level also we have to increase as the indicators of successful MRA. Okay, so these all are about the nursing implications about the maternal reactions theory. Now come to the write a note on the oxytocin. So as we know, oxytocin is also known as a pitocin. Okay, so which is the mainly one, it's a very much helpful drug for the labor. Okay, so that is the main medicines you can say like during the labor period. So you have to remind, like if the mother is primigravida, so you have to make sure that the 10 to 15 ampule, that pitocin or oxytocin should be there with a 500 ml NS or the normal saline or the dextrose glucose saline. Okay, now come to the multiple gravidarum. Okay, so for that only 5 units of the oxytocin along with 500 ml DNS or the normal NS or the normal saline. Okay, so this is the main equation. You have to keep it in mind. Whatever situation is there, you have to make sure that either it is a primigravida or the multigravidarum. Okay, so if it is primigravida, so 10 to 15 units or the ampules of oxytocin with the 500 ml DNS or NS, and for the multigravida 505 units or the 5 ampules of the pitocin or oxytocin along with 500 ml DNS. So see, oxytocin is a drug which is mainly stimulate the uterine contractions, the smooth muscle. Okay, so it is mainly used for induce or augmentations of the labor, means sometimes for reducing the labor pain or sometimes for increasing the labor pain, control the postpartum hemorrhage, and also we have to facilitate the uterine involution after delivery or abortion. So you must remind this control the postpartum hemorrhage, how it should be possible after before giving birth also we have to continue the normal saline with the pitocin, and also after delivery also we have to give an injection of a oxytocin. Then only it will be possible to maintain the hormonal balance, which will be helpful to prevent the PPH or postpartum hemorrhage. Okay, so now come to the classification. So first class is peptide hormone. Okay, so peptide hormone under this example is oxytocin. So what is the remark? So naturally it's occurring hormone synthesized in the hypothalamus hypothalamus, which is stored in the posterior pituitary gland. So it is produced in the hypothalamus, but it's stored in the posterior pituitary. So whenever our body is needed of the oxytocin, so from where it will release, that is, it will release from the posterior pituitary gland. Okay, now come to the ergot alkaloids. So in the ergot alkaloids, what are the example? Argometrin, under this argonovine, as well as the methyl marginotin. Okay, so in this it is derived from the claviceps purpura or the fungus, so which is cause a stronger as well as a sustained uterine contraction. Next is the prostaglandin. So under this PGF2 alpha, which is also known as a carbopost, PGE1, which is also known as a misoprostol, and PGE2, which is also known as a dinoprostol. Okay, so it's mainly potent the uterotonics, which is used for the induction of labor, abortion, and then PPH control or postpartum hemorrhage control. Now come to the mechanism of action. So oxytocin, which is act as a oxytocin receptor like G protein coupled receptor on the uterine myometrium, and it's also increase the intracellular calcium level, which is leading to the rhythmic uterine contraction, and this the uterus is also becomes more sensitive for the oxytocin as the pregnancy progress, especially near to the term position. Now come to the ergot alkaloids, so which is stimulate the alpha adrenergic blocker and then serotonin 5-HT receptors in the uterine muscle, which is mainly helpful for sustaining the tonic uterine contraction, and also they act mainly on the upper segment of the uterus. So when it will started to work on the upper segment of the uterus, so what will happen from this upper segment, this contraction start will the contraction will start and it will come to the in downside. Okay, then it will come to down, then it will cover to the middle portion, then it will cover to the corner portion. So like that way the contraction will be circulating in all over uterus. Okay, so that's why it is mainly if you produce the ergot alkaloid, so obviously it will act on the only upper segment of the uterus. Okay, next is a prostaglandin. So in this you have to active the specific PG receptor in the uterine smooth muscle. Okay, so which is mainly increasing the intracellular calcium 2 plus ion, which is cause a strong uterine contraction. So whenever the mother is having, like if the mother is having calcium deficiency, so for that obviously along with the oxytocin and DNS, along with that based on the physician order and then mother health condition, we also have to give the calcium in the IV infusion. Okay, so calcium is one of the most important component for maintaining the uterine contraction as well as the smooth muscle movement and contractile. Okay, so that's why calcium like Ca2 plus ion we have to provide, and also it's also have like helpful for promotion of cervical ripening, like softening and dilatations of the cervix. So from the 2 centimeter it starts to open like 2 to 4, 4 to 6, 6 to 8, 8 to 10. Okay, so these all are about mechanism of action. Now come to the next question, that is enumerate the theories which is applied in our midwifery practices. Okay, so first is the nursing theory, basic nursing theory, that is also related with our maternal nursing, right? First is the Florence Nightingale environmental theory. So in that we are mainly focused on creating an optimal environment like cleanliness, hygiene, ventilation, light to promote the healing and well-being of the mother and baby. Next is a Virginia Henderson need theory. So it is emphasize the assisting mothers to gain the independence in meeting their basic needs during their childbearing period. Next is a Dorothea Oram self-care deficit theory. So it's mainly guiding the midwifery or the midwives in supporting the women for maintaining the self-care during pregnancy and postpartum period. Next is the Sister Callister Roy adaptation model. So in this they views the pregnancy and childbirth as a adaptive process which is requiring the physiological, psychological as well as the social adjustment. Next is a Jean Watson's theory of the human caring. So it's mainly promotes the compassionate holistic care and then therapeutic relationship between the midwifery as well as the woman. Next come to the next theory, that is Hildegard Papula's interpersonal relationship theory. So it's mainly stresses the importance of a communication and then relationship between nurse and then mother and baby. Now last is a Madeline Linger's transcultural nursing theory, which is support mainly culturally sensitive maternity care, which is respect the woman's beliefs, thoughts and values. Okay, so these all are about the basic nursing theory. It is related the maternal nursing. So how it is related, that only overview I have given, and based on this only the midwifery specific theory that I am going to tell. First is a Jean Ball's continuity of the care model. So it's mainly highlights the importance of ongoing relationship between the woman and her midwife throughout the maternity journey. Next is the Caroline Fleet's partnership model. So in that model, they are mainly focused on empowering the woman through the shared decision making as well as informed choices. Next is the Ina May Gaskin's holistic birth model. So in this model, they are mainly emphasizing the natural birth, trust is the baby's process, and then minimal intervention. Next is a Shelia Ketzina's humanistic approach to childbirth. So it is mainly helpful for using of the childbirth as a normal life event, not a medical procedure, valuing women's autonomy and experience. Next one is the Nike Lab and then the Billy Hunter's midwifery partnership model. So through this model, they promote the collaboration, mutual respect, and then equality between woman and midwife. So now come to the next important question, that is explain the anesthesia and analgesia during the obstetric period. Okay, so this is also one of the most important questions for the 10 marks as well as the 5 marks. So see, first question, analgesic, which is the drugs, is relieve the pain without causing loss of consciousness. Analgesia, which is refers the absence of response for the stimuli which would normally be painful. And also in obstetrics, analgesia is aimed as a relieving pain during labor and delivery while they are maintaining the maternal consciousness, cooperations, and then fetal safety. So pain in labor, in the first stage of labor, but they are doing pain due to the uterine contraction and cervical dilatation, you can see. So it's transmitted via T10 to lumbar 1 spinal segment. So second stage of labor, this pain is happened due to the stretching of the vulva and then distressing of the pelvic floor, nasal, vagina as well as the perineum. So at that time, this analgesic is transmitted via the S2 to S4 segments. Next is the classifications. Okay, first category is non-pharmacological method. So in that example, relaxation, breathing techniques, hypnosis, acupuncture, TNS. And what is the remarks? It is a very safe and used in the early stage of labor. Next category is systemic analgesic. So when you are giving like what are the example? Opioid like pethidine, then phenytoin, morphine as well as NSAIDs. Okay, non-steroidal anti-inflammatory drugs. So it's mainly rarely given during the labor pain. What is the remarks? Like cross placenta may cause the neonatal depression. Next is the inhalation analgesia. So in that you can give the Entosk. Okay, so Entosk mask is nothing but in that mask you can get the 50% of N2O along with 50% of the oxygen suppressions, and also the halothane, which is rarely used now. So what is the remarks? It's very much effective, self-administered. Okay, now come to the systemic analgesic. One by one I am going to discuss. So under that there are two categories. First is the sedative and then hypnosis. So which is used for the opioids for promote the rest like diazepam, promethazine as well as the hydroxyzine. Now come to the opioid analgesic. So in this it's mainly commonly used as example pethidine or the meperidine, which is given 50 to 100 mg IM through every 3 to 4 hours, and then phenytoin 25 to 50 microgram through the IV in a short acting, and morphine, which is rarely used due to the prolonged neonatal effects. Now come to the mechanism. So which is mainly act on the mu opioid receptor in the central nervous system for altering the pain reception. What are the advantage? Easy to administer and effective in early labor. So what are the disadvantage? Like maternal nausea, vomiting, drowsiness, which is also may cause a respiratory infection, depression in mother and newborn, and also cross placenta, like the placenta barrier they might be cross, and which is mainly leading cause for the neonatal depression. Next is the interference with the fetal monitoring or the CTG changes. So what are the precautions they need to take? Avoid within 1 hour of expected delivery, and antidote also we have to keep it ready. So as an antidote we can give the naloxone 0.1 mg per kg IV to neonate if the fetus is depressed. Now come to the inhalation analgesia. So in this I said Entonox. Okay, so in this nitrous oxide you can get 50% and oxygen 50%. So what is the mechanism? It's mainly helpful for the depress the CNS or the central nervous system pain pathway, rapid onset and then offset. So the mother can't feel the pain. Next is the administration. So self-administered via face masks as on onset of the contraction, and it is maximum effect within the 45 seconds. Next is the advantage, like simple, rapid and effective, and no effect you can see on the uterine contractions or the fetal heart rate, and also it is a patient can control that particular ratio. Next is the disadvantage. So may cause a lightheadedness, nausea, drowsiness, and also sometimes requires the cooperation. Now come to the regional anesthesia. So in this the regional analgesia, first is the epidural. So what are the drugs might be used? Local anesthetics like bupivacaine as well as the lidocaine. Next is a plus or minus opioids. So in that phenytoin or the sulfentanyl or for the synergistic effect. And what are the procedure? Through the catheter we have to insert in the epidural space like lumbar 3 or lumbar 4 or in between lumbar 4 to lumbar 5. Next is continuous and then intermittent infusions. Next is the advantage. So it is a very much excellent pain relief method throughout the labor, and also the mother awake and cooperative in that procedure can extend for the cesarean section anesthesia. Now come to the disadvantage. So for that may cause the hypotension, urinary detention, prolonged second stage of labor, and also it requires the trained anesthetics as well as monitoring. And what are the rare complications like dural, the puncture, headache, infections, epidural hematoma. Next is a contraindication. So in this contraindication, coagulopathy, infection at site, severe hypovolemia as well as the patient refusal you can see. Next come to the next that is spinal analgesia. So in this the single injection you can give into the subarachnoid space, and also it provide the rapid onset but the shorter duration, and also it's very much commonly used for the cesarean section rather than the normal delivery. Next is a combined spinal epidural or the CAC. So in this rapid onset and prolonged duration you can see for the epidural and spinal, and also it's very much popular for the modern obstetric analgesia. Next is the pudendal nerve block. So for the second stage of the labor period or delivery period or instrumental delivery they are going to use this, and also it's you can give this injection near to the vaginal nerve via pudendal nerve via vagina, okay, and it relieves the peripheral pain only, and it's no effect on the uterine contraction. Next is the local infiltration analgesia. So for the episiotomy or the perineal repair they used to inject it, and example lidocaine 1% or the bupivacaine 0.25%, and it is a very much simple, effective as well as a minimal risk. Now come to the analgesic method. So first is the opioids, spinal, Intonox as well as the epidural. So what are the maternal consciousness? In the opioids you have to give awake wise, then spinal also during the awake period, Intonox also during awake period, and epidural also during awake period. So pain relief like opioids they can relieve the pain moderately, spinal they can relieve the pain very much excellently like short duration, then Intonox also moderately, and epidural also excellently. Now come to the next question, that is explain in detail about the adoption procedure in India. So adoption through the Indian government is primarily by the following laws. First is Hindu Adoption and then Maintenance Act HAMA, which was introduced in the 1956, and it's mainly applicable for the Hindu, Buddhist, Jain and Sikh, and also it allows the Hindus for adopt a child legally as per the religious as well as the personal beliefs, and their providers give the clear guidance for the eligibility of adoptive parents and children. Next is the Juvenile Justice, Care and Protection of Children Act, which was introduced in the year of 2015, and through this act it is mainly applicable to all the citizens of India respective of the religion, and overseas adoption of the orphaned, abandoned as well as the surrendered children, and also it is implemented through the Central Adoption Resource Authority or the CARA. Next is the Central Adoption Resource Authority, which was named as a CARA. So it is a statutory body under the Ministry of Women and then Children Development, which is mainly regulate all the inter-country as well as the domestic adoptions in our India, and it also provides a online rapport system or the portal system for the adoption. So that is CARA online registration. Next is the eligibility criteria for the parents. First is domestic adoption. So married couples minimum age should be 25 years and maximum age 55 years. Age difference between child and then adoptive parents must be at least 25 years. So single parent, single woman can adopt, single man can adopt only under specific circumstances, and health like physically and mentally fit to care the child. Next is the financial stability, should have the adequate resources to raise a child. Next is a child eligibility. adoptability. So the children, they should be legally free for the adoption, like orphan, abandoned, as well as the surrender. And then age criteria may vary. Infants are generally preferred by the adoptive parents. Now come to the next question, that is explain in detail about independent nurse midwifery practitioner. Okay, so as an independent nurse midwifery practitioner, we have to get a license, right? So in that we have to make sure some policies, that is trained in both nursing as well as midwifery field, provide the independent care to women during pregnancy, childbirth, postpartum, as well as the newborn care period. And also it focus on preventive care, health promotion, and patient education. And also it emphasize on the holistic as well as the patient-centered approach. So see the scope of practice. First is the prenatal care, means monitoring maternal health, fetal growth and development, and also performing the routine physical assessment as well as laboratory test screening, and counseling on the nutrition, exercise, and healthy lifestyle choice, means during the antenatal period. Now come to the labor and delivery period. So at that time they are managing the normal labor as well as the childbirth independently. They are providing the emotional support, guidance to the mother and family, and also they are monitoring the fetal and maternal well-being during labor. Now come to the newborn care. So they are assessing the newborn health and development, and also they are providing the guidance about the immediate care, nutrition, then immunization as well as early development and weight of the baby. And also they are identifying the signs of neonatal complications and initiating the timely referrals. Now come to the health educations and then counseling. So in that they are mainly offering the community education on the reproductive health, prenatal care, contraception, and then sexual health. And also they are advocating for the maternal and then child health agents. Now come to the qualification and then training. So first is the educational requirements. What are the education should be done for that particular nurses? First is registered nurse degree or the diploma, additional midwifery practitioner, often 1 to 2 years as a postgraduate program, and some regions or advanced nursing practices or advanced practiced nurse may complete a master's degree in nursing midwifery. Next is a licensure, must hold a nurse license. They must be certified as a midwife throughout the national as well as the religion midwifery board, and independence practice may require the special authorization or the registration depending on the country. Now come to the skills required. So what are the skills is required? Clinical skills in the sense prenatal, labor, delivery, postpartum care, emergency care skills in the sense like neonatal resuscitation, then natural maternal complications. So communication and counseling skills, and critical thinking and decision making of the independent practice. Now come to the next question, that is describe the management information and evaluation system. So MIES is nothing but obviously it is a very much structured method framework which is mainly collecting, analyzing, interpreting and evaluating the health related data for supporting the decision making, then evaluations of the healthcare services. Okay, so what are the main purpose in the maternal nursing? First is the data driven decision making. Okay, so they are mainly like provide the accurate and then timely information for hospital managers, nurses, midwives as well as other co-workers, and is also helpful for the planning maternal health program, allocating the resource and addressing the service gaps. Next is the monitoring and evaluation. So through this data they can progress the maternal health indicators such as the maternity rate, preventive skills, prenatal skills, and skill birth attendance and postnatal care coverage, and also they assess the effectiveness of the intervention and identifies area needing the improvement. Next is the quality improvement. So through this they facilitate the evidence-based practice in maternal nursing and ensure that maternal care services meet standardized protocols and guidelines. Next is the resource management. So through this they have the inventory management of medicine, equipment, and staffing in the maternal health units, and also it prevents the shortage or wastage in maternal health delivery. Okay, now come to the components. So first is data collection. So through these sources of data like antenatal record, delivery, then register, postnatal follow-up, family planning record, data, etc. Next is types. First is quantitative and qualitative. So in the quantitative they are mainly seeing the number of prenatal visit, delivery, postnatal visit, etc., maternal death, then premature birth rate, death rate, everything. Next is the qualitative like patient satisfaction rate, quality of counseling, adherence to the protocols. Now come to the data processing. So through this first compilation, coding, and then entry into the computerized system or the manual register, and also they're ensuring the accuracy, consistency, and standardization of the maternal health data. Next is the data analysis. So through this they analyze the trends such as maternal mortality, morbidity patterns, risk factor in pregnancy, utilization of maternal health services. Next is the informed decision making. So through this they are mainly producing the reports and dashboard for different stakeholders. Okay, so like nurses and midwives, hospital managers, healthy policy makers, etc. Last is evaluation. So through this the data they are measuring the effectiveness, efficiency and quality of maternal nursing service, and it's also complications management effectiveness. Now come to the next question, that is describe the various biochemical and biophysical tests for fetal well-being. Now come to the biochemical test. It is a nothing but chemical compositions of the maternal blood, amniotic fluid and fetal blood, and also providing the direct evidence of the fetal health, oxygenation and metabolic function. So first is a maternal serum biochemical test. So under this, alpha fetoprotein, which is produced by the baby fetal liver, and use high levels may indicate the neural tube defects, low levels it also indicate the chromosomal abnormalities. Okay, next is a human chorionic gonadotropin or the HCG. So source is produced by trophoblast, and it's part of a biochemical screening for mainly assessing the Down syndrome for the baby. Next is the amniotic fluid biochemical test. So under this obtained via the amniocentesis, and then biochemical parameters which also may reflect the maturity as well as the stress. So first is the lecithin or the sphygmomyelin ratio. Okay, so in this what is the purpose? Mainly they assess the fetal lung maturity, and normal if the L versus AS is ratio is greater than 2.0, so it suggests the mature lung. Next is the phosphatidyl glycero or the PG. So in this purpose confirms the lung maturity if L by S ratio is borderline. Next is the presence, like indicates the mature lung. Next is fetal karyotyping. So it's mainly detects the chromosomal abnormalities but not acute diseases. Next is a fetal blood sampling, so or the cardiosynthesis or the peri-umbilical blood sampling. Okay, so it is mainly performed usually in the second or third trimester of the high risk pregnancy. So under this test performing like pH and blood gases like oxygen, carbon dioxide, HCO3 minus. So low pH indicate the fetal acidosis, and low oxygen or high carbon dioxide, which is indicates the hypoxia. Next is the lactate measurement. So if elevate the lactation is there, then which is leads to the anaerobic metabolism, and which is also leads to the fetal hypoxia. Next is the hemoglobin or hematocrit, which is evaluate the anemia and then polycythemia. Now come to the biophysical test. So it is a evaluate physical as well as the physiological parameters of fetus, like test are non-invasive and often used for the ongoing monitoring. So first is a non-stress test. It is a mainly procedure external fetal lung monitor, which is applied for 20 to 40 minutes and monitor the signals. Each fetal movement and FHR response should be recorded. Now come to the interpretation. So reactive, like greater than equal to 2 accelerations of the FHR greater than equal to 15 beats per minute, which is lasting greater than equal to 15 seconds within 20 minutes, and it's indicate the good fetal oxygenation. Next is the non-reactive, means fails to meet the criteria, which is leads to the may indicate fetal hypoxia or sleep. Further testing required. Next is the contraction stress test. So in this the oxytocin infusion or the nipple stimulation to indicate the contraction, and then FHR then monitoring for the more declarations. So what is the interpretation? Negative CST indicates no late declarations or which is leads to the fetal well-being, and next positive CST, which repetitive late declarations, which is leads to the fetal hypoxia or placental insufficiency. Now come to the biophysical profile. So with the main components 5 parameters. Okay, so fetal breathing movement, gross body movement, fetal tone, amniotic fluid volume and NST results. So scoring, if a ratio is 8 to 10 means normal or low risk, 6 means equivalent or equivocal or the repeat or deliver if term, and less than equal to 4 means abnormal, high risk, consider the urgent delivery. Next is a Doppler ultrasound or the fetal circulation assessment. So high resistance means placental insufficiency, absent or the reversed end diastolic flow means severe compromise. Next is a middle cerebral dietary Doppler, so which is mainly detect the brain sparing effect in the hypoxic fetuses. Next is a ductus venosus Doppler abnormal flow, which is indicate the severe fetal compromise acidosis risk. Now come to the next question, that is explain the general physiological puerperial changes during postnatal period. So puerperia means after delivery up to the 6 weeks. Okay, so in that reproductive system has changes. So for the uterus involution you can see means the uterus started to shrink to back to the pre-pregnancy stage. So immediately after birth, like less the near to the 1000 gram, 1 week near to the 50 gram, 6 weeks near to the 50 to 100 gram, normal pre-pregnancy size. Now come to the fundal position. So day 1 you can see fundus level in the umbilicus area. Day 2 you can see 1 centimeter below of the umbilicus, and gradually it descends into the pelvis by the 2 weeks. So what is the lochia? Vaginal discharge, you can see there are 3 types: rubra, serosa and alba. So rubra is red, first 3 to 4 days you can see, like lochia serosa is pinkish brown, you can see 4 to 10 days, and alba is whitish, you can see 10 to 21 days. Now come to the cervix. So it is very much soft immediately after birth, gradually forming, and waist also you can see the cervical opening which is remains slightly dilated, never fully returns to the pre-pregnancy stage. Now come to the vagina. So in the vagina it returns to the near pre-pregnancy stage by 6 to 8 weeks, and vagina mucosa which is remain for the some time if the mother is not latching. Now come to the ovaries. So ovaries, it is a non-lactating woman. Ovulation may resume around 6 to 8 weeks, and lactating woman, lactational amenorrhea delays ovulation. Prolactin suppresses gonadotropin releasing hormone. Now come to the breast. So colostrum you can see present for first to 2 to 3 days. Lactation begin 3 to 5 days after postpartum, and breast fullness, tenderness, engorgement are very much common symptoms. And prolactin and oxytocin, they are mainly regulating the milk secretions and then ejections. Now come to the cardiovascular system. So blood volume is gradually decreased. Heart rate and cardiac output also returning in the pre-pregnancy stage level over 2 to 6 weeks, and blood pressure also usually stable. Now come to the hematological changes like hemoglobin and hematocrit. So it might be low due to the blood loss, gradually normalized. Then WBC count is also elevated during the early puerperium, which is normalized within a week, and clotting factor which is remains elevated for a few weeks. Next is the urinary system. So in this, kidney functions which is gradually returns to the pre-pregnancy stage, and diuresis which is increase the urine output in first few days for eliminating the excess fluid which is accumulated during the pregnancy. Next is a GI system. So for that, often this bowel function is often delayed due to the analgesia side effect, decrease the motility and peripheral trauma, and appetite which is usually returns quickly, and constipation also is very much common in early puerperium. Now come to the musculoskeletal system. So it is the abdominal ball. It's loosened due to the stretched muscle, gradually improves. Joints means relaxing effect, whereof some women may have the joint discomfort and weight gradual reductions of a pregnancy. Now come to the endocrine system. So first is placental hormone which is dropped sharply after delivery, like estrogen, progesterone, HPL, and next is the thyroid hormone may fluctuate. Some women experience the transient postpartum thyroiditis. Next is the skin and hair. So first is pigmentations, linea nigra and then melasma gradually fade. Hair loss which is a telogen effluvium may occur 2 to 4 months, which is postpartum due to the hormonal changes. Next is the stretch marks which is remain but may lighten over time. Next is the psychological and then emotional changes. So mood swing you can see is very much common in first 1 to 2 weeks, and support and monitoring are very much crucial for prevention of the postpartum depression. Next is the NICU. So we know NICU is nothing but it is a specialized area or the in hospital which are providing the intensive medical and nursing care for the newborn infants who all are premature, have the low birth weight as well as congenital anomalies or other complications. So first see the locations and then layout. So it should be located close to the operation room, operation theatre or the postnatal ward for the quick movement. So layout should be includes like reception, record area, hand washing, rounding area, intensive care area, then intermittent or the step down care area, and then isolation room for the infectious cases, milk preparation and storage area, equipment and then Lylan storage, prenatal counseling, and then waiting area. So what are the equipments? First is resuscitation equipment. So in this radiant warmer, suction, ambu bag, monitoring device like pulse oximeter, cardiac monitoring as well as BP monitor, respiratory support like CPAP, BPAP, then oxygenation, ventilation, etc. Now come to the thermal control. So in this you can see incubator, radiant warmer, feeding and nutrition. So in this infusion pump, feeding tubes, and infection control like hand washing station, sterilization, and air filters. Levels of neonatal care. So there are mainly 3 levels. So under this first level, basic newborn care unit. So it's a normal newborn, mild jaundice. Level 2 special care newborn area. So what is provide for the moderately ill babies, feeding issues, and mild RDS. Now come to the level 3, which is mainly provide the advanced intensive care, mechanical ventilation, and then surfactant therapy. Staffing pattern, neonatologist or the pediatrician, overall management, then neonatal nurse, it should be there round to clock, and then monitoring and care. Respiratory therapist like ventilation management. Dietitian also should be there, nutritional assessment, and technician and support staff, they mainly should be there for the maintenance and cleanliness, and counselors or the social worker, the prenatal support, and then education. And nurse patient ratio, if the level 3 care means 1 nurse is to 1 baby, and level 2 care means 1 nurse is to 2-3 baby. Okay, so what is the infection control? Obviously hand hygiene, aseptic technique, reverse the visitor policy, then regulator of the sterilizations, and next is proper waste disposal, use of the PPE. Next is separation isolation area for the infectious cases. Now come to the menopause or the 2 marks question. So menopause is nothing but it is a natural biological process which marks the end of a menstruations for the woman. Okay, typically age is 45 to 55, and cause is nothing but is the production of estrogen and progesterone level in the circulation. Symptoms: hot flashes, night sweats, mood changes, vaginal dryness, sleep disturbance, as well as irregular periods. Okay. Now come to the next, that is inductions of the labor. So what do you mean by the induction of labor? It is a artificially initiation of uterine contractions before the spontaneous onset of labor, and main aim is achieving a vaginal delivery. So purpose is nothing but bring on labor while continuing the pregnancy poses a greater risk for the mother or baby than delivering. So methods, there are several methods. Medical method used to the oxytocin or prostaglandin. Next is a mechanical method. It is a devices like amniotomy, artificial rupture of membrane, or the Foley's catheter for dilating the cervix. Next is an indication. So in this example, like postpartum pregnancy, rupture of membrane without the labor, hypertension or the preeclampsia, intrauterine growth restriction, etc. Now come to the ectopic pregnancy. So ectopic pregnancy, it is a medical condition, so where this fertilized egg is implants and begins to grow outside of the lining of uterus. Okay, so any part it can be, but not any part of uterus. So that time it's called as a ectopic pregnancy. Most commonly it's happen in fallopian tube, okay, called as tubal pregnancy, but it also can occur in the ovary, sometimes cervix, sometimes the abdominal cavity also. So because this lactations, it cannot support the growth of normal pregnancy, so an ectopic pregnancy can't result in the birth of viable baby, and it also may cause a life-threatening conditions for the mother. So just remind, during the pregnancy time, which hormone is growing up? That is HCG, right? So for the normal pregnancy, within 48 hours the HCG hormone is growing, okay. But if the mother is having ectopic pregnancy, so within 24 hours only HCG hormone will be rising up very much gradually. And one of the more symptom, that is the spotted bleeding, okay. So for the ectopic pregnancy, you can see the mother has a spotted bleeding during the menstruation, or sometimes while the urinating, okay. So that is the ectopic pregnancy. Now come to the infertility. So infertility, which is defined as the inability for a sexually active non-contracepting couple for achieving the pregnancy after 12 months, okay. So what is this points? Mainly you have to remember, if the woman is 35 or the older, infertility is often evaluated after 6 months of the trying, because fertility declines with the age. So infertility may due to the factors involving female, male, and both partners. So it can be classified as a 2 types, primary and secondary. So primary infertility, when pregnancy has never occurred, and the secondary infertility, when pregnancy has occurred previously, but after that they can't able to give the baby. Now come to the next, that is hyperemesis gravidarum. So it is a severe form of the nausea and vomiting during pregnancy, which is goes to beyond typically the morning sickness, and it also can be very much significant of the dehydration, electrolyte imbalance, weight loss, and the nutritional deficiency. So what are the things you have to keep it in your mind? It occurs in first trimester but can persist the longer, and symptoms include like persistent vomiting, inability to keep food or the fluids down, fatigue, and then sometimes ketonuria. So exact cause is fully not understood, but may involve the hormonal changes, particularly elevated the level of the human chorionic gonadotropin hormone or the estrogen. And then mainly treatment focus on the hydration, electrolyte correction, nutritional support, and then anemetic medications. Now come to the fertility window. So what do you mean by the fertility window? It is referred as a period in the menstrual cycle when the persons with the ovaries is most likely to conceive if they have the unprotected sexual intercourse. So the window occurs around the time of the ovulation, with an egg is released from the ovary and it's available for the fertilization. So you just see the timing, it usually spans like within 5 to 6 days. Okay, so the 5 days leading to ovulation plus the day of after ovulation. Okay, and peak fertility, the day of ovulation and then day before ovulation are considered the most fertile days. Why the 5 to 6 days? Because the female sperm is around to stay only maximum 5 days in your uterine. Okay, after that it started to die or it started to less their motility. So that's why 5 to 6 days you have to keep in your hand for the fertilization. So whenever which date you are ovulated, so that day and before the day of the ovulation and after the day of ovulation, so these 3 days are the most peak point for the proper ovulation period. Now come to the next, that is lie and presentation. This is also one of the most important questions. So what do you mean by the fetal lie? Which is describe the relationship between long axis of the fetus head to toe and the long axis of the maternal spine. Okay, so what are the types? Longitudinal, transverse and oblique. Longitudinal in the sense where the fetus spine is parallel to the mother spine and it is the most common and ideal for vaginal delivery. Next is a transverse lie when the fetus spine is perpendicular to the mother spine. So vaginal delivery it's usually not possible, cesarean section is only the main option. Next is the oblique lie, so when the fetus is an angle between longitudinal and transverse, so it's usually unstable and often changes to the longitudinal and transverse before labor. Now come to the fetal presentation. So it's referred as a part of the fetus. It's closest to the cervix and will be delivered first. So there are so many presentation is there. First is cephalic presentations. So first is the most common and preferred. So in this vertex, okay, crown of the head it is present first, means in the birth side. So next is the face present first and brow, forehead present first. So that these all are under cephalic presentation. Now come to the bridge presentation or the buttocks presentation. So under these 3 types, flank bridge in the sense buttocks first, legs should be extended. Next is a complete bridge, so buttocks should be first, then legs, and both are flexed. Next is a footling bridge, so one of both feet when it's come out through the vagina, so that is called footling bridge. Now come to the shoulder presentation, when the anterior or the posterior shoulder, whatever this bony part should be present on the vagina for the delivery first, so that time it's called as a shoulder presentation. So whenever which part is presenting first during the delivery, so based on that part it's called as a presentations. Okay, if face, eyebrow or vertex means cephalic presentation. So in the bridge means buttocks or knee or footling, anything, that means the bridge presentation, and shoulder means anterior shoulder or posterior shoulder or the bony point of the shoulder. Now come to the list, the immediate care of the newborn. First is initial assessment like chest flaring, grunting, breathing, then APGA score, APGA score, that is also under initial assessment. Next is airway management. Okay, chest flaring as well as a breathing pattern also we have to check. Next is a breathing support. So if the breathing difficulty is there, so as a breathing support we can give the oxygen mask or sometimes the ambu bag. Next is the circulations and then heart rate. Next is thermal care we have to provide. Immediately after delivery we have to shift the baby to the radiant warmer. Next is a cord care. So cord care means the sense after delivery of the baby, after 1 minute we have to cut the clamp, cut the cord and then clamp it. So after that we have to collect the blood from the cord for the sampling, and at the same time through the cord we also have to give injections. Okay, so which will be helpful for the baby to growing up. Next is an identifications and safety. So for that identification band we have to provide. Medication and prophylaxis, like immediately after birth we have to give the medication, that is vitamin K injections. Okay, and sometimes BCG or OPV also you can provide during the birth only. Next is the early breastfeeding, and next is observation. So how the baby is developing, baby's weight, height, everything we have to observe. Now come to the low birth weight baby. So it is defined as a newborn baby who weighs less than 2500 gram or the 5 pounds 8 ounces at the birth, which is regardless to the gestational age. So normal birth weight greater than equal to 2500 gram. Very low birth weight means less than 1500 gram, and extremely low birth weight means less than 1000 grams. So love mainly causes is premature birth, intrauterine growth retardation, maternal malnutrition, illness, lifestyle factors such as smoking, alcohol, etc. Now come to the list out obstetric emergency like maternal maternal hemorrhage, hypertensive disorder, obstetric labor emergency, fetal distress, infection related emergency, thromboembolic events, as well as other acute obstetric conditions. Okay, so now come to the, I'll give you some more important questions. See, discuss the importance of antenatal care in reducing the maternal and neonatal morbidity and mortality. Means here you have to focus only on maternity care. Next is explain the role of maternal nurse in assessing the high risk pregnancy. Next is describe the physiological, psychological changes in pregnancy and their nursing implications. The stages of labor and role of a nurse in supporting women throughout the labor. Means each and every stage from the first to till the fourth you have to write it. Next, discuss the management of complication during labor such as preterm labor, prolonged labor, as well as the fetal distress. Okay. Next is explain the pain management technique during labor and the nurse's role for providing the pharmacological and non-pharmacological interventions. Okay. Next is discuss the care of mother in the immediate postpartum period, including assessment, monitoring, and prevention of complication. Explain the breastfeeding and techniques, benefits and common problems, including the nurse's role in promoting the successful breastfeeding. Describe the management of postpartum hemorrhage and nurse's responsibility in emergency situation. Explain the gestational diabetes mellitus, including risk factor, clinical features, management, and nursing care. Discuss the hypertensive disorders of the pregnancy, including preeclampsia, eclampsia, with the emphasis on nursing interventions. Describe the maternal infection during pregnancy and their impact on maternal and fetal health. Describe the fetal development, assessment, and monitoring during pregnancy. And next question, explain the nursing care of the newborn immediately after birth, including resuscitation and then AMGA score. So resuscitation, what is the ratio? 2:1. Okay, so for the newborn baby. Next is discuss the management of preterm and then low birth weight infants, which is highlight the nurse's role. So in this session I discussed so many important topics from the maternal nursing, but I suggest you to read out all the textbooks and also read out all the topics, important questions from the previous year question paper, which is already uploaded in our applications. And if you want to know more in detail about each and every topic, then please go to the Easiness application, take the classes and take the notes and read it for your upcoming exam. I hope you all understood my sessions. Again, we'll meet in next session. Till that, keep learning and stay tuned with the Easiness, and all the best for your exam. Okay, thank you.